So in Canada, for the elderly CLL population, right now our options are really bendamustine and rituximab. A lot of Canadian centres participated on the previous study that looked at chlorambucil and obinutuzumab, which is a different anti-CD20 antibody. But the difficulty is that's still a little bit hard to get. So really bendamustine and rituximab is probably most of the options that we have in Canada across the country for our elderly patients. Ibrutinib is an interesting drug. It's a small molecule. It's an oral pill. It's given once daily for patients. So the benefit there, of course, is that it's a pill as opposed to an intravenous therapy for patients. Ibrutinib really established itself as an option for these patients from a previous clinical trial that compared it to chlorambucil alone. The difficulty with that is that even though it was superior to that of chlorambucil, using chlorambucil as your control arm was felt to be inferior just because it's not actually a standard treatment that we normally give, as most of our elderly patients, as long as they're healthy enough, should be getting a combination with something that's directed against CD20 like rituximab. So that's what led to a different abstract at ASH last year that looked at ibrutinib versus ibrutinib with rituximab. But the problem in that scenario was that they did it in a relapse scenario. So that's why the study presently, where they moved it all the way up to the front line, actually was very, very important to actually establish. So, obviously building on all the previous studies, the current study was more so as a proof of concept to make sure it worked in the front line in comparison to a more standard treatment option. So the study design was actually a 3-arm study, randomized 1:1:1. So it was an evenly balanced study between patients that were randomized to the standard, which is bendamustine rituximab, versus ibrutinib by itself or ibrutinib with rituximab. And so what they were able to demonstrate is that, first and foremost, that the ibrutinib plus the rituximab were actually equivalent to each other. So in other words, patients receiving ibrutinib by itself or with rituximab actually had pretty much overlapping survival outcomes. But either way, as long as you received an ibrutinib-containing regimen, you had a superior progression-free survival compared to that of bendamustine and rituximab. But the study right now is only at roughly about a median follow-up time of about 30 months. And so there's no overall survival distinction at this point in time. I don't know if you'll ever get that because they allowed crossover for patients. So if you were on the bendamustine-containing arm, if you relapse, you're allowed to then cross over to the ibrutinib-containing arm. In terms of safety, actually, a lot of the safety was pretty straightforward. So given that bendamustine and rituximab is a traditional chemotherapy-containing combination, you see a lot more thrombocytopenia, neutropenia, and anemia. And as a result of that, you see a higher degree of febrile neutropenia, which is probably the more important factor to look at. From the ibrutinib side of things, you see a very similar type of side effect profile, specifically that of atrial fibrillation, slightly higher, around 2 to 3% versus 0 on the bendamustine arm, and as well as hypertension. And that one actually ended up being close to 29 to 30%, but again, quite manageable. None of that was actually that severe to begin with. None of it actually led to a hypertensive issue that actually needed to be addressed in an urgent basis. So I think going forward after this study, I think it does really establish ibrutinib as a clear choice actually in frontline therapy for elderly CLL patients. What I think is going to be somewhat difficult actually in the Canadian market is actually more so how do we address the financial complication associated with this. The study doesn't actually allow for patients to stop. Basically, patients continue ibrutinib until the time they progress. And that could be for quite a long time. I mean, we're talking about a progression-free survival so far at the 2-year mark of about 88% in the ibrutinib-containing arms, which means that the large majority of them are still on therapy. Whereas bendamustine and rituximab, they receive their six rounds of chemotherapy and then they're done. They actually have a treatment-free interval thereafter. So there's going to be a financial consideration that has to be brought into all of this, just because we're a single-payer system. Now, whether patients can stop or not is an interesting one. Yeah, I think the other interesting thing is actually going to be the overall survival data, to be honest, because if patients actually receive bendamustine and rituximab first, have a treatment-free window, and then receive ibrutinib afterwards, if they have identical survival to those that receive ibrutinib up front, there may be a bit of a concern as to whether or not you truly need to receive ibrutinib up front if at the end of the day you're still getting the same overall survival, in other words, the length of life that they have to them. That's going to bring into the questions about quality of life as well as some of the overall patient perspective. So I think patient input is going to be very important in that respect to decide ibrutinib's role.